Hi, everyone. Thanks for joining us. My name is Vincent Streva. I am the Clinical Laboratory Director of Sherman Abrams Laboratory, which is a clinical laboratory based in Brooklyn, New York. Our patient population serves the greater New York City metropolitan area and surrounding counties. And the largest patient populations we have are in the boroughs of Brooklyn and Queens in Manhattan. And so today I'm going to talk to you a little bit about COVID-19. Particularly, I want to try and focus a little bit on the role of antigen testing today and where I see antigen testing sort of moving in the near future. So I will not belabor too much in terms of background because I think that SARS-CoV-2 is something that a lot of people are thinking about and sort of have a relatively good background on, but I will sort of remind everyone that the first laboratory confirmed case of SARS-CoV-2 in the United States was back in January of this year in Washington State. And in the intervening year, basically, SARS-CoV-2, as we know, has spread to become a worldwide pandemic. And as of November 3rd, 47 million people worldwide have tested positive for SARS-CoV-2. Resulting in 1.21 million worldwide deaths. And the picture in the United States is equally grim, nearly 9.5 million US cases and over 320,000 US deaths. So our laboratory is located in Brooklyn, which is in the state of New York. So I will talk a little bit about New York State, and you'll hear a little bit later about some New York State testing recommendations for antigen testing as well. So in New York State, we got started on this pandemic very early on, so the biggest impact we felt in the months of March and April when we started and had our largest ongoing outbreak. But since testing began in New York in March, the state has tested nearly 15 million people by PCR, with over 500,000 positive test results, and unfortunately 33,000 people who have died of COVID-19 in New York State. So as of this recording, the most recently available numbers, just to show you a snapshot of where New York State testing is right now, are from the 1st of November. So as of that date, New York is testing roughly 100,000 individuals by PCR every day, with a positivity rate in the range of around 1.5% to 2%. And if you look at this map, you'll see that the darker shades, particularly the reds in the southern part of the state, show where the largest number of positive cases have been reported in the state. And this makes sense because if you know anything about the geography of New York, you'll know that those darker colors correspond to the larger metropolitan or urban centers in the state. So our laboratory is in Brooklyn, which is right at the southern part of this map here in one of the reddest zones. So we've had a large number of COVID cases that we have tested and reported. So New York has done a lot to emphasize the importance of testing, particularly PCR testing. And one of the biggest pushes from state and local health officials and government has been accessibility of testing. New York has set up testing centers throughout the state to provide anyone who wants a test in New York the ability to get a test. And one of the pushes that the state and local officials are making are that PCR results should be available within 48 hours of specimen collection so that they are more easily able to guide treatment and are more clinically useful. So this aggressive screening strategy is sort of depicted in this chart from the Department of Health. So if basically in the blue bars, it plots the total number of COVID test results performed in the state from when we started testing in March through the most recent date. That date is available basically through the beginning of November. And you can see a very large increase, particularly starting over the summer, in the number of tests performed in New York State. Perhaps a little bit understated just because of the magnitude of the bars. is what you see in yellow over here, which is the positivity rate. So you can see that in March and April, when we had our peak SARS-CoV-2 activity, that there are significant numbers of positive test results. And fortunately, since then, in the state, due to public health measures, social distancing, etc., we've been able to sort of flatten that curve. So SARS-CoV-2 testing, in hindsight now, we have the benefit of knowing more than we did in March when the outbreak hit us in New York. So now, for example, we know that perhaps predictably, viral RNA becomes detectable by PCR a few days before the onset of symptoms. So those are the magenta and blue lines on this chart. So PCR is detectable in nasopharyngeal or sputum specimens, basically, most often by the time of symptom onset and certainly a few days later. However, what you'll also notice is, unlike some other respiratory diseases, it seems like viral, or at least RNA positivity by PCR seems to linger a bit, in some instances more than 2 weeks after the onset of symptoms. And I'll talk a little bit more about this later. But what I just want to point out here is if you compare the blue and magenta lines, which are the PCR, the presence of RNA by PCR, to the red line, which is the recovery of basically infectious viral particles by culture, you will see that PCR remains positive long after virus is no longer culturable from a clinical specimen. One thing we didn't know, certainly at the beginning of the pandemic, that we know now is the sort of unusual antibody response that we see to SARS-CoV-2. So generally with a viral illness, you would expect an initial IgM antibody response to then be followed by an IgG antibody response some days later. However, if you look here in the purple and green hatched lines, you can see that IgM and IgG antibodies for SARS-CoV-2 tend to rise and peak at roughly the same time. And so currently the testing recommendations don't really indicate any preference for one antibody over the other in terms of indicating a recent or prior infection. So let's go back now to what I was saying before. So we are a clinical laboratory in Brooklyn, and in March, our outbreak started here in New York, and providers were across the area were just scrambling to bring on some kind of diagnostic testing for patients who they thought were either exposed to or had SARS-CoV-2. So our laboratory brought on PCR testing for SARS-CoV-2 in March, and this next slide shows you our PCR testing results. So you may be a little bit surprised to see, just will point out that each month we test roughly 25,000 SARS-CoV-2 PCR specimens. So you may be surprised to see here, we started testing in March, and in March, the month of March, when our outbreak was happening here in New York, we had a nearly 60% PCR positivity rate, which is truly almost unfathomable. It was a very hard time to run a clinical laboratory in the city of New York. And then you'll see we also that continued the high positivity rate into April, where it was over 30%. And that's because the first half of the month was basically also very high, 50 to 60%. And then in the second half of April, once New York had sort of instituted more strict shutdown and quarantine procedures and encouraged mask wearing and other social distancing procedures, we were effectively able to flatten the curve in New York, which you can see we did a very good job of for the summer months with very low positivity rates through the summer. Those rates now are maybe a little bit higher with back to school, but still we're not seeing anything close to what we saw at the beginning of this pandemic in March and April. So I've told you that we began PCR testing in March, and providers saw the results of their patients' PCR tests. However, in March, access to PCR testing reagents, consumables, instrumentation was very limited, not just at our laboratory, but laboratories across the country. And so providers were not able to test everyone who they wanted to test. So naturally, seeing the high 60% positivity rate for PCR, providers wondered, well, how can I determine which of my patients may have previously had SARS-CoV-2 infection and either been unable to access a PCR test or either had it before PCR testing was even available widespread. And so naturally, providers are used to thinking about antibodies, and so they immediately started reaching out to laboratories across the region looking for SARS-CoV-2 antibody assays. And in March and the beginning of April, there were no FDA-approved or no FDA EUA emergency use authorization approved antibody tests for COVID. However, what there were, and what the FDA did allow, was manufacturers to distribute antibody tests to providers and laboratories without going through the EUA process, because they had a backlog and they didn't want to be accused, I guess, of hindering testing and access to testing. So effectively what this wound up doing was flooding the market with, quite frankly, tests that were not well tested, verified, tests that we could not confirm the accuracy of, but providers were desperate, and so they began using many of these tests, lateral flow immunoassays, that just came to them from mysterious manufacturers, and they used these assays at the point of care to make clinical decisions, and I think that the very good many of these assays were clinically useless, to be quite honest. Fortunately, in April, a number of manufacturers got FDA EUA for antibody tests, more reliable, reviewed by the FDA, and had received emergency use authorization. And so our laboratory decided to go with one of these FDA EUA authorized tests that was one of the first to the market, and that was the Diasorin SARS-CoV-2 IgG assay, which detects antibodies against the SARS-CoV-2 spike protein, which is probably one of the more immunogenic proteins from the virus. So we started testing in April of this year, and every month we test about 30,000 patients for antibodies. And you'll see in April and May, our data showed a 45% antibody positivity rate from everyone that we tested in the laboratory. And many of these people were people who were never symptomatic, but because the prevalence in New York City and particularly in Brooklyn and Queens was so high, very large proportion of our patient population tested positive for COVID IgG antibodies. And this has been fairly consistent. We haven't had a huge number, as you saw in the previous slide, of new infections over the summer. So most of these positive antibody tests that we're seeing in September and October are most likely patients who were infected during our outbreak in March and April and who still have IgG antibodies. So one thing we did look at early in the course of this pandemic in our laboratory in the month of April was how antibody responses were sort of broken up by age group. And so that's here on the left panel, if you take a look. And you can see that for us in the month of April, the antibody positive prevalence rate was relatively consistent for most age groups, except for a little bump on the left, where we see a slightly higher but significantly higher positivity rate in patients let's say between the ages of 10 and 20 years of age. And this was interesting to us because these were patients who we know usually do not experience ill effects from a SARS-CoV-2 infection in terms of symptoms or outcomes, but it does seem, based on this data, that they do have robust antibody responses and make IgG antibodies regardless of that, or maybe because of that. Again, we don't know for sure at this time. One other thing we looked at here on the right is we worked with a provider at an urgent care facility who worked with us to grade patients as they came into his facility based on their symptoms, with 0 on the x-axis representing asymptomatic patients, and a 4 on the x-axis representing the most critically ill patients who required either hospitalization or oxygen support. And here in this figure, we look at the antibody response in terms of a semi-quantitative antibody response using the deosorin liaison IgG assay. The response of the IgG to that symptom severity. And we see in both males and females a relation between increased symptom severity and increased levels of IgG antibodies, which maybe says that more critically ill patients have a stronger antibody response. And again, there's still more to be studied here, but when we published this in the Journal of Diagnostic Microbiology and Infectious Diseases in May, it was sort of new information for everyone. So I want to transition a little bit from the laboratory to the point of care, because I think that during a pandemic such as this, point of care testing is very important. People are walking into urgent cares and they want the results available to them before they leave for the day, basically within 20, 30 minutes. So there are a number of point of care tests that have received FDA emergency use authorization, including one EUA point of care antibody test, and the other 14 split evenly between point of care molecular and antigen tests. The point of care molecular tests tend to be hard for facilities to come by. Reagents, consumables, and test instrumentation is short. So the vast majority of point of care testing that's performed today in the clinic is antigen testing. And the 3 of the most common point of care antigen tests are the Quidel Sofia, which was the first to receive FDA EUA, the BD Veritor, and the Abbott Binax Now. I mentioned a bit earlier, just to point out that EUA and EUN are not necessarily created equally. Again, the FDA allowed for manufacturers to release tests onto the market without going through the emergency use authorization approval process, which is not to say that all EUN tests are inherently worse than an EUA test, just that there's less oversight of them. So as these sort of point of care antigen testing kits came onto the market, we began to hear reports that they weren't very good, their sensitivity was bad, there are a lot of false negatives, false positives. No one really had a very good sense of what was going on. And so these are just 2 popular press headlines. Some recently, coronavirus antigen tests, quick and cheap, but too often wrong. A rapid virus test falters in people without symptoms, study finds. And so we're seeing a lot in the popular press, especially, about the performance of antigen tests. And it's not always necessarily the most accurate source of information, or at least not the most accurate interpretation of what I believe the data actually show. That being said, we also see sort of the other side of this. So just the other day, I heard that Slovakia intends to test its entire population using antigen testing, which I think is pretty neat. So we'll see. I'm sure we'll see in the coming weeks how that shakes out. But in order to talk about, the accuracy and sensitivity of PCR testing, of antigen testing, I think first we need to talk about the PCR testing, which is sort of the gold standard now. And I think we need to talk about PCR testing in terms of sensitivity versus clinical utility. So I've just summarized a review of 29 studies that look at PCR and compare it to viral culture, which if you remember from an earlier slide, viral culture is generally a measure of infectious viral particles, with the idea being that culture negative samples are non-infectious. So if you're not able to grow a virus in culture from a patient sample, then that patient is not likely to be able to pass infectious virion on to someone else. So looking at a number of studies, and it always is difficult to compare one manufacturer's PCR assay to another, but generally the consensus is that for PCRs with CT values greater than 30, so weak positive PCRs, there is limited to no culture growth seen from these specimens. So high positive PCRs generally do not correlate with the ability to recover virus from a specimen, which we can then say implies that high positive PCR positive specimens don't correlate to infectivity necessarily. And so why is this the case? I mentioned also earlier, we seem to now know that RNA shedding for SARS-CoV-2 lasts a bit longer than we would have originally expected. So we generally see RNA shedding 14 days and beyond past the onset of symptoms, whereas we don't really see positive viral culture results beyond about 8 days or so from symptoms. And so this sort of brings us to, the joys of running the clinical laboratory during the global pandemic. In March, when we first brought PCR testing online, I got calls every day from clients wanting to make sure that the PCR test we were running was a good PCR test that was sensitive enough to catch everything. And now, sort of as providers are wrapping their heads around the implications of high CT value samples and how they relate to RNA shedding versus positive culture results, they're now starting to call and ask, well, is maybe your lab's PCR test overly sensitive? I've even had patients call the lab and say, oh, I read in the New York Times about CT values. Can you tell me about the CT values in your laboratory? So there's a lot going on here and a lot left for us to learn and unpack about PCR testing. So I'm just going to talk a little bit briefly about it, but again, it won't be a comprehensive discussion for sure. So this is a figure from the New England Journal of Medicine by a group out of Boston, and they sort of compare two hypothetical tests. So you see that they list the bottom line is a high analytic sensitivity test, which they're calling a PCR, and the top line is a low analytic sensitivity test, which I think you can think of as sort of an antigen test. And the argument here that the authors are making is that these high analytic tests, these PCRs, we know that resources are limited, tests are limited. We can't test serially a patient every day. So you may, because you only get decreased frequency of testing, you may miss the infectious period of that patient. So for example, if you look at the high analytic sensitivity line, you have an initial test which is negative before that patient has made any virus, which is fine. That patient is negative, that patient is not making any virus. But then because of lack of testing or whatnot, by the time a patient gets a result after they have symptoms, they're in a post-infectious period. So they're in that period after culture is no longer positive. However, because the PCR test has a high sensitivity, they've got a positive PCR result. So the question remains, and I'm not going to answer this question certainly, but as a provider, what do you do with a positive PCR result like this from what we're calling a post-infectious patient. Now, contrast this to the line that's labeled low analytic sensitivity, where the argument is if this is a readily available test that you can just pump out thousands and thousands and thousands every day of, then you can test a patient every day and you'll get a negative result 4 days in a row until that patient finally has a viral load that's clinically significant, and then you'll get a positive test result and you have caught that patient in that infectious window. So again, I think the importance here is a balance of clinical sensitivity with clinical utility. Is a more sensitive assay necessarily better? And then another question that's up in the air is, does antigen testing capture the majority of clinically relevant cases? And again, I think that there's no one-size-fits-all answer for that, and it will depend on the proper evaluation of antigen assays as they continue to be released on the market. However, I just want to spend a very short amount of time saying that there is good evidence that antigen testing correlates with viral load. So here's a paper from the International Journal of Infectious Diseases, and you can see very clearly that SARS-CoV-2 antigen response on the y-axis, or antigen level on the y-axis, is linearly and directly correlated with SARS-CoV-2 viral load on the x-axis. And also out of a group in the Netherlands, published as a preprint, they look at 3 antigen tests with differing sensitivities, tests A, B, and C, the vertical dashed lines. And these different tests of these 3, so on the x-axis is the limit of detection, basically, or the viral load of the sample. So you can see that test A is more sensitive than test B, is more sensitive than test C. And they look at how good of a job these tests do with calling samples that are also positive by culture. And again, remember, the idea is that in order for you to consider a patient as infectious, you have to sort of accept that they will be culture positive. They may not necessarily be PCR negative at that point. And so you can see that as the sensitivity decreases, actually, you get a bit of a better correlation to positive cultures than for the more sensitive tests. And this is not obviously to say that you want to throw sensitivity out the window, but I think it is important to at least understand this and balance sensitivity versus clinical utility. For what it is worth, the state of New York has recommendations for testing using antigens, or antigen testing, and they are slightly different depending on whether the patient is from a symptomatic on the left or an asymptomatic patient population on the right. Basically, in both cases, they tell you that a positive antigen test is sufficient, that patient has COVID, and they should quarantine for the appropriate amount of time. And then the difference is how they recommend dealing with a negative antigen test. So in a symptomatic population, they recommend immediately following a negative antigen test with a confirmatory RT-PCR. And if that RT-PCR is positive, obviously the patient may or may not be infectious. Again, think about sensitivity versus clinical utility. However, the recommendation right now from the state of New York is to quarantine that patient because of the positive PCR test. In an asymptomatic patient population, they actually are a little bit less strong about their recommendation for following a negative antigen test with PCR testing. They may recommend it, but they're not going to, I don't think, enforce it. So this sort of brings me to my next slide, which is using antigen testing in a diagnostic setting. So I use diagnostic setting to mean testing of symptomatic patients, and using antigen testing in a screening setting. And I use a screening setting to mean testing asymptomatic patients. So for example, in a mass back to school drive where you want to test a school of 1,000 children, you don't expect them to be positive. I would call this a screening test. And so there have been some studies that look at the sensitivity of antigen testing versus PCR in diagnostic testing, so in symptomatic patients. And we see a relatively good, up to 90% sensitivity versus PCR in symptomatic patients, which I think is pretty good. But when we test in asymptomatic patients for a screening population, we see a much poorer sensitivity. Some studies report as low as 30% versus PCR. But again, the question is, does this matter? Are these clinically relevant infections? And I think that's still something that moving forward we're going to have to wrap our heads around and think about. However, I just want to point out one additional reason of why I think antigen testing will be important moving forward. So I think PCR testing will remain the gold standard because it is a very sensitive methodology. However, if we understand that sometimes more sensitive is not necessarily better, then I think we have a place for antigen testing, particularly in light of a recent survey by the Association of Molecular Pathology, AMP, who surveyed clinical labs throughout the country and inquired about testing shortages. And so, many laboratories, at least a third of laboratories, report limited access to either PCR testing platforms, PCR reagents, RNA extraction reagents, or consumables for PCR testing. And this has resulted in the majority of laboratories running 3 or more methods for COVID PCR, which is certainly a burden on the laboratory, and also not necessarily ideal for serial monitoring of patients who may be tested on different platforms, even within the same laboratory. One other just quick note is that these shortages do not just impact COVID testing. So because of changes to supply chains and manufacturing by manufacturers to ramp up production of COVID-related tests, they've had to oftentimes decrease production of non-COVID related tests. So we've seen significant allocation issues with reagents for things like STD testing or other infectious disease testing, viral loads, etc. So there are impacts to mass PCR testing that are rippling through clinical laboratories now. And I do think that if we can transition some of this testing to antigen testing, hopefully some of these issues will be mitigated. But to do this, we sort of need to make sure, and I just want to end here by saying what I'm hoping for in terms of widespread antigen testing. We have to make sure that the antigen tests we use are properly vetted and they're used appropriately to replace PCR testing. So for example, if you have a highly symptomatic patient, you probably will do fine testing them by antigen. You can save a PCR test. However, in order to really know this, I think we need to do a proper comparison of any antigen test to PCR and culture to make sure that we have that right balance between sensitivity and clinical relevance. And I do think that at this point, the best location for things like this to happen are in CLIA labs and not at point of care facilities. I think that just inherently laboratories are better equipped to properly evaluate these antigen tests. And I think one important thing moving forward will be alternative specimen types and transport medias. So we have shortages of VTMs and UTMs. We have shortages of nasopharyngeal swabs. So the ability to test for antigen in swabs and saline or in saliva specimens, I think will be key to moving laboratory testing to the next stage and where this pandemic needs to go. And then finally, I think that we really need to have some high throughput solutions and move away from sort of these low throughput point of care settings into a high throughput testing platform at a clinical laboratory. So thank you for spending this time with me. I would like to thank the wonderful team of techs that work for me in the laboratory, particularly led by our lab supervisor, Rihanna Akhtar, as well as some others in the laboratory, Josh, Ben, and Ike, who have been instrumental in sort of keeping the management of the laboratory under control during this very difficult time. And thanks to Nelson Ham, who was our sort of clinical provider who helped us with data for our paper that I talked about on one slide. And then finally, I just would like to end with an important reminder: please wear your masks. Thanks, and I'm happy to answer any questions by email.